Hey everybody, I'm back today. This is Kman. I'm an emergency physician at Ohio State and also do disaster response with Ohio Task Force 1, which is FEMA's urban search and rescue team. I was invited back by the Columbus Medical Association for the trilogy of COVID-19 updates and to talk about some other emergency stuff today. So that's kind of what I want to do. They asked me to talk about, the impact of COVID-19 on emergency departments in ways that we don't, obviously think about. So one of the things that, I had talked about in the other video blogs that we have done is that we needed space, staff, and supplies to see the influx or surge of COVID patients. And one way we got ourselves extra space to do that was to cancel elective surgeries and procedures. And at Ohio State, we did this on March 19th. There's a huge financial impact to do that. It's not something that was, just done without a lot of thought. But what we did was we canceled surgical procedures that weren't necessary. And necessary procedures are ones that are done to avoid risk to life. If there's permanent dysfunction, if there's progression of disease or cancer, those procedures are still done. But something like an elective knee replacement, for example, or, doing something like, a cosmetic procedure, those are things that were put on hold. And frankly, volumes are down, but volumes are also down in the emergency department. And I think a lot of that has to do with people staying home, which is great. We appreciate you doing that for the health of the labor pool and healthcare providers. But you shouldn't stay home if you have an emergency. And that's kind of what I wanted to talk about today. So we need space, we need staff, we need supplies, but we're here to take care of you. And I saw a report in one of the lay press articles about somebody who was having a heart attack but was too scared to go to the emergency department. And so hopefully we can dispel kind of some of those myths. So sick patients still need to come. Let me tell you that I think hospitals are very safe. They are a place where COVID-19 is concentrated. There's no doubt about that. But we're screening every person at the door of the hospital. And even, in the tunnels of the hospital, going from one area to another, there's screening stations. So employees and visitors get their temperatures taken. They get a mask applied to their face, and visitors are limited. So, unfortunately, this has been pretty well publicized, but we aren't allowing visitors because we're trying to limit the spread of COVID-19. I think our environmental services group is doing a great job with cleaning all the rooms thoroughly and making sure COVID's off of all those surfaces. So a couple things that you shouldn't ignore. If you're having shortness of breath to the point where you can't catch your breath, you should be seen by a medical provider or at least talk to your doctor. In COVID-19, shortness of breath typically sets in between the 4th and 8th day of illness, and it can progress to respiratory failure. This has been well publicized. One of the things that's different about a normal pneumonia is people with COVID-19 get a non-productive cough and worsening shortness of breath. So, doctors will consider getting x-rays. We aren't getting chest x-rays on every COVID-19 patient. It's not the way to make the diagnosis, but it's an important piece for people who have shortness of breath and chest pain. Also, folks get anxiety and air hunger. So this is a pretty well described that people get anxious. They feel like they can't catch their breath. They can't breathe. And they come in and we put a pulse oximeter on their finger and their O2 sats are very low. So if you're having shortness of breath, come in and we can check your vital signs. And then also, chest pain's been described as well. So, this issue of getting a chest x-ray, Chris Como on CNN talked a lot about his chest x-ray, and so it's in the lay press, so I thought I'd talk about it a little bit. Here's the other thing that you need to think about. COVID-19 increases the risk of blood clots in the body. So we are getting some data and evidence out of China, although it's limited, but autopsies have revealed blood clots in the kidneys and other organs like the lungs and the brain. And so if you're short of breath, this could be a blood clot in the lung, or it could be a cardiac issue. So you should come to the emergency department. Shortness of breath, worsening shortness of breath with exertion, those are things that shouldn't be ignored. Um, for the providers out there, routine use of CAT scan is not recommended. Use your decision tools like your Wells criteria or your D-dimer to decide, who gets a CT scan. But I'll tell you, last week when I was working, I had a patient come in with severe chest and back pain. And we did a D-dimer, which was extremely elevated, did a CAT scan, and she had multiple pulmonary emboli, but tested negative for COVID-19, which makes me wonder if we would have done a follow-up, did she potentially have it and we didn't pick it up on the test, or was this just an unlucky person that has pulmonary emboli? As far as treatment for, the docs out there, consider heparinizing people with an elevated D-dimer. I'm saying consider. There aren't strong guidelines or evidence on this, but I am seeing at our medical center therapeutic heparin given to people with a strong suspicion for thromboembolic disease, and at the very least, a higher prophylactic dose of Lovenox than we normally give for prophylaxis. If patients have you suspect massive pulmonary emboli or embolism and are unstable, then that would be an indication for giving TPA or systemic thromboembolic agents. So the other thing that we have to think about is cardiac stuff. So again, I saw in the late press someone was having a heart attack and was afraid to come to the emergency department. Please don't be afraid to come in. We're pretty good at heart attacks if we catch them in time. And so you need to come in. But one of the things you may not know is COVID-19 has a higher mortality rate in patients with cardiovascular disease. So that includes people with heart failure, people with strokes, people with end-stage kidney disease. COVID-19 has a higher mortality rate. So we need to see you if you're having issues. Some of the literature suggests that acute cardiac injury from myocardial infarction or heart attacks and myocarditis can be as high as 17%. We're seeing arrhythmias at a rate of about 17%. We're seeing heart failure in these patients because of these issues. And again, we're seeing blood clots as well. So, the population of folks that we're concerned about are people who are greater than 65. Usually male patients have a higher incidence of coronary artery disease, people with diabetes, hypertension, patients who are immunosuppressed, so have a history of transplant. Those are people that we're certainly concerned about. If you're in those categories and you're having chest pain and shortness of breath, do not ignore your symptoms. As far as how we're doing stuff now in the emergency department, if the medics bring to us someone with a ST segment elevation MI, like the EKG on this slide, instead of them going straight to the cath lab, we're screening those patients in the emergency department for symptoms of COVID. If they have some nausea, diaphoresis, chest pain, but no fever, no signs of COVID-19, they may go straight up to the cath lab. If we're really concerned that they have COVID-19, we might go ahead and start thrombolytics or TPA in those patients, especially the stable ones that we can keep, in the hospital and watch. If somebody's unstable and they come in with an ST segment elevation MI, those patients are likely to go get screened for COVID-19 and then go straight to the cath lab. Thrombolytics are not recommended for non-ST segment elevation MI, and troponin monitoring is really recommended in most of these patients because of the myocardial injuries that we can see. Consider getting echocardiograms early so you could see what that cardiac function is doing on echocardiogram, and get your cardiologist involved if you're concerned. One of the things that came out last week, and one of my partners, Ash Panchal, was on this this group that wrote these new guidelines, was a new ACLS cardiac arrest algorithm. And I think I just wanted to point out, I think what I think are the important points. First of all, cardiac arrest is an aerosol generating event that's high risk to get providers infected. So the first thing you have to do is adequate PPE. Go ahead and put on your N95, your eye protection, your gown, your gloves, and think about, is resuscitation appropriate? How long has the patient been down? What's the cause of this? Do we need to do this procedure? Most often the answer is going to be yes. We're going to start CPR and we're going to start our ACLS, but think about that, because providers are going to get put at risk throughout managing the cardiac arrest. And then when you think about intubation, intubation again is going to be an aerosol generating procedure. Think about making sure you have a viral filter on your mask. If you're bagging the patient, which we try to avoid if we can, make sure you have a tight seal. So these were new recommendations that came out last week. The, uh, the the citations on the slide, if you want to go ahead and look through that. I think we need to know how to deal with cardiac arrest in COVID-19 patients. The other thing, so venous thromboembolism disease, of course, can affect the brain, and that can manifest itself in strokes. A study out of China found that over 35% of patients had some type of neurosymptom. So altered mental status, confusion, disorientation, dizziness, headaches, even seizures, and very, I think popularly it's been recognized that patients can get impairment in taste and smell. There was a separate article that I read from last week in Medscape, which is kind of a mix of lay medicine and a medical journal, but they looked at interviews from New Orleans, Chicago, and Seattle, and they all saw that their stroke volumes were down. So what's the dichotomy here? If we're saying that COVID-19 causes stroke-like symptoms or can cause neurosymptoms, why aren't we seeing those patients? And I think a lot of people are concluding that the patients with mini strokes or minor symptoms are afraid to come to the emergency department or reluctant to come to the emergency department. So again, this is a plea. If you're having weakness, you can't move your arm, your speech is garbled, you can't find the words to say the things you want to say, come to the emergency department. We're going to take care of you. We'll do the best we can to make sure that it's safe when we come here. But if we catch a stroke too late, time is brain, you could be left with impairment that would be lifelong. So it's important to recognize those things as well. As far as other stuff, just don't forget that life's happening. So I saw a funny meme about I have these allergic shiners. I get bad seasonal allergies, so I'm on the Nasonex and the eye drops and the Zyrtec. Do I have seasonal allergies? Do I need to go to the emergency department or just take a Claritin? Everything's in bloom right now. See your doctor if you need help with your emergencies, with your allergies. As far as viruses, we're still seeing seasonal flu. We're still seeing other viruses. We still see community-acquired pneumonia. If you have those things, see your healthcare provider. Tick-borne illness. So this is an incident of Lyme disease. So Ohio has kind of equal parts Lyme disease and Rocky Mountain spotted fever when it comes to tick-borne illness. But when it comes to Lyme disease, you could see that here we are getting ready to have this huge ramp in tick-borne illness. And I'm curious how this is going to be this year. I see a lot of people outdoors getting exercise. The more you're in the tall grass, people are still golfing. We could have, a fair amount of tick-borne illness. And then, injuries. I've seen people working temporary jobs for Amazon or doing deliveries or lifting more. So, if you get yourself injured, come into the emergency department. as well, or see your doctor. I mean, we're here to help you with those things. So just to summarize, we appreciate that you're staying home. That would be the first message I would deliver. I think Ohio's done an amazing job of flattening the curve. And I think, as I said in our prior interview, what we're seeing with inmates, nursing homes, and other institutions is people that can't socially isolate are getting COVID-19. It's spreading through like wildfire. So that's a social experiment in that the people that are staying home, they're out at their house, we're preventing the spread of that. So thank you for staying home. That said, if you have shortness of breath, chest pain, altered mental status, confusion, weakness, stroke-like symptoms, or symptoms of COVID-19, call your doctor. Don't hesitate to come to the emergency department, because if you sit home with a stroke or a heart attack, you could have lifelong disability or even death. So that was my chat for today, my video blog. I hope you enjoyed it. I want to thank the Columbus Medical Association for letting me come back and talk to you and provide a little bit of education and content. Please don't hesitate to contact me if you have other questions.